Hi all, welcome back to Prakash Emergency Medicine Lecture Series. After a long gap, I'm doing the videos again. In the coming few days, I will be doing lectures on ECG. We will be learning how to record a 12-lead ECG, how to interpret a 12-lead ECG, and also the rhythm interpretation. Lead 2 is the most commonly used lead for rhythm interpretation as it is directly in line with the spread of the cardiac impulse. The cardiac impulse spreads from the SA node comes down to the AV node. There is a certain amount of delay in the AV node. Then through the bundle branches comes down, reaches the apex of the ventricles, and then spreads up on the free walls of the ventricles. So lead 2 is the lead which records the potential difference between the right arm and the left foot, ninth ounce triangle. So these in exactly the cardiac vector. This lead is used as the lead for rhythm interpretation most commonly. Lead 6 can also be used as it is directive overlies the SA node. Coming to rhythm analysis, there are 5 steps in rhythm analysis. Step 1 is determination of the regularity. Step 2 is calculating the rate. Step 3 is assessing the P waves. Step 4 is determining the PR interval. Step 5 is determining the QRS duration. So once you follow these 5 steps and interpret the results, you will come to a conclusion, the diagnosis. First of all, let's look at how we are going to determine the regularity. Regularity is usually determined by calculating the distance from between two R waves called the RR interval. RR interval should always be equal when you call it as a regular rhythm. In general practice, you will not be able to calculate each RR interval. So what you do, you take a strip of white paper and mark the peaks of first three R waves. And then you can slide the paper and the R waves. If all your dots are coinciding with the peaks of the R waves exactly, then it's said to be a regular rhythm. Regular are the equidistant apart, occasionally irregular, or regularly irregular rhythms can be there, or a completely irregularly irregular rhythm can be present. Step 2 is the rate calculation. Again, rate calculation is done by determining the RR interval. Count the number of R waves in a 6-second rhythm strip, then multiply it by 10. Even if the rhythm is regular or irregular, this method will give you an approximate rate. Count the R waves in a 6-second strip, that is 30 large boxes, and then multiply that with 10, which gives you the heart rate. So in this presented ECG, there are 1, 2, 3, 4, 5, 6, 7, 8, 9 R waves visible. The 10th R wave is just falling on the outer border. So rate is somewhere between 90 to 100. There are other complicated methods to calculate. You can use 300 beats per method or 150 beats per method. Rate is 300 by RR interval large squares or 1500 by RR interval in small squares. But doing the previous one is very simple. Next comes assessing the P waves. Look whether the P waves are present or not. Are they P waves? So the first positive deflection in the ECG is the P wave. You all know that. So see the arrow marks, they are pointing to the P waves. So if the P wave is present, that means the impulse is originating from the SA node. Though all P waves look alike, if all the impulses are originating from SA node, all the P waves should be looking morphologically similar, similar height and similar width, and morphology should be similar. Or The PWAVES can be originating from different foci in the atria, as in multifocal atrial tachycardia, wherein you see different morphologies of PWAVES. Do the PWAVES occur at regular rates? So just like how you calculated the RR interval, you need to calculate the PP interval. So that determines the regularity of the SA nodal firing. Is there one P-wave before each QRS complex? This is most important, the relationship between P-waves and the QRS complex. So for each P-wave, there should be a following QRS complex. The P-wave denotes the atrial activity, QRS complex denotes the ventricular activity. So each atrial activity should be followed by a ventricular activity in a normal sinus rhythm. Next comes the determination of the PR interval. As you all know, PR interval is the AV nodal delay. That's right. PR interval is the AV nodal delay. Its normal is 0.1 to 0.2 seconds. That is 3 to 5 boxes, small boxes. So in this given, next step is determination of the QRS duration. QRS duration determines the total period of depolarization of the ventricles. Normal is 0.04 to 0.12 seconds. If it is less than 120 milliseconds, it is 0.12 seconds, you call it as a narrow complex. If it is more than 120 milliseconds, you call it as a wide complex. Narrow complex QRS is usually due to sinus nodal discharge, and wide QRS complex is due to discharge anywhere below the EAV node. So in summary, you have 5 points. You need to calculate the regularity. Look at this ECG. All R waves are equidistant. So this is a regular. How many R waves are present in the given 30 second, 6 second strip? 1, 2, 3, 4, 5, 6, 7. At the border, you have the 10th wave. So the rate is 90 to 95 beats per minute. Regularity is the regular. P waves are normal. See, this P wave, each P wave is followed by QRS complex, and all the P waves look morphologically similar. PR interval is 0.12 milliseconds, which is normal, and the QRS duration is 0.08 seconds. Again, it's a normal. So overall, what is the rhythm here? It's a normal sinus rhythm. So we look at some of the other rhythms. Yes, in the first ECG, go step by step. Regularity is a regular rhythm. There are 1, 2, 3, 4, 5, 6, 7 R waves in the 30-second strip, 6-second strip. So the rate is 70. Anything below 50 you call bradyarrhythmia. Anything above 150 you call tachyarrhythmia. Between that, it should be sinus rhythm. So there's P wave. Each wave is followed by a QRS complex, and each P wave looks, all the P waves look similar in morphology. QRS duration is 2 boxes, 0.08 seconds. So this is a normal sinus rhythm. The second ECG, there are only 3 waves visible. Yes, it's regular. The RR interval is equal. You have a P wave there, P wave here. P wave morphology looks similar. PR interval 1, 2, 3 boxes. Heart rate is 30. QRS duration 1, 2 small boxes, 0.08 seconds. So it is a sinus bradycardia. Next ECG, rhythm appears regular. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. So the rate is 14 multiplied by 10, 140 is the rate. Do you have a P wave here? Yes, there is a P wave. Each P wave is followed by QRS complex, and the PR interval is normal, QRS duration is narrow. So what is the rhythm? It's a sinus tachycardia. Yes, visible complexes just going up and down, and it appears very regular. There is no P wave. You cannot calculate the PR interval. Whatever you are seeing here is the QRS complexes, and the QRS complexes are almost 7 small boxes. It's a wide QRS complex, and the rate is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, about 180. So it's a ventricular tachycardia. Next one, rhythm appears regular. Rate 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. Rate is 170. Tachycardia. Is there a P wave? There is no P wave. When there is no P wave, no question of PR interval. And you have QRS complexes which are narrow, about 2 small boxes wide. So it's a narrow complex, a regular tachycardia. A narrow complex regular tachycardia is a SVT, supraventricular tachycardia. Yes, the next ECG. Is the rhythm regular? No, it's irregular. Irregularly irregular. Rate 1, 2, 3, 4, 5, 6, 7, 8. 8 is the rate. There are no P waves, and the QRS appears narrow. Irregular, narrow complex tachycardia, also called as EAF. AF can be with controlled ventricular rate or uncontrolled ventricular rate. Yes, in this ECG is going completely haphazard. No two waves are looking similar to each other. Most chaotic rhythm. This is the rhythm of ventricular fibrillation. Next ECG, no P waves, only wide complex QRS complexes are visible. When you look at it first, it appears to be irregular, but when you look at it keenly, starting with some amount of amplitude, say 10 mm, and the amplitude is gradually increasing on both the sides, and then again once it reaches the peak, it's coming back to normal and starting again. So these torsades, depointers, or multifocal ventricular tachycardia. So now let us look at how to treat these bradycardias once you know the rhythm. Assess appropriateness for the clinical condition. Heart rate is typically less than 50 per minute if bradyarrhythmia. Identify and treat the underlying cause. Maintain a patent airway. Assist the breathing as necessary. Supplement oxygen if the patient is hypoxemic. Connect to the cardiac monitor to identify the rhythm. Monitor blood pressure and oximetry and try to normalize them. Obtain an IV access early in the course of the disease. 12-lead ECG can be done if time permits. Don't delay therapy for getting a 12-lead ECG done. So even after you have regularized the blood pressure oximetry, if there is persistent bradyarrhythmia causing one of the 5 features of instability. What are the features of instability? Hypotension. Yes, hypotension is caused by bradycardia, acutely altered mental status, any signs of shock, ischemic chest discomfort, acute heart failure. If any of these features are present, the patient is said to be unstable. If none of these present are features are present. Patient is said to be stable. You need to monitor and observe the patient. Stable bradyarrhythmia doesn't require any immediate therapy. The patient is unstable, you start with atropine. If atropine is ineffective, you can go for transcutaneous spacing, or if transcutaneous spacing is not immediately available or expertise is not available to start transcutaneous spacing immediately, you can start dopamine infusion or epinephrine infusion. Consider expert consultation and transvenous spacing as early as possible. So coming to the doses and details, atropine should be given IV, or if you are not able to get an IV line, you can go with IO axis. First dose is 0.5 milligrams bolus. Repeat every 3 to 5 minutes. A maximum of 3 milligrams or 6 doses can be given. Dopamine infusion usually start at an infusion rate of 2 to 20 micrograms per kg per minute. Titrate to the effect so that BP improves. Or instead of epinephrine, dopamine, you can use epinephrine IV infusion, 2 to 10 micrograms per minute infusion, titrated for the patient's response. If you are seeing a tachycardia, again the same steps as for appropriateness of the clinical condition. Heart rate is typically greater than 150 per minute in a tachyarrhythmic rhythm. Most important thing here is identifying, treating the underlying cause, maintain a patent airway, assist breathing if necessary, supplement oxygen if the patient is hypoxemic, connect to a cardiac monitor to identify the rhythm, monitor blood pressure and oximetry. Persistent tachyarrhythmia that is causing hypotension, acutely altered mental status, signs of shock, ischemic chest discomfort or acute heart failure. If these features are present, your therapy is going to be the synchronized cardioversion. Consider sedation before giving the shock. If regular narrow complex, you can consider adenosine instead of synchronized cardioversion. None of these features are present. Look at the QRS complex. Is it narrow or wide? If it is a wide QRS complex that is greater than 120 milliseconds, you can get an IV access, get a 12-lead ECG done. If available, consider adenosine only if regular and monomorphic. Consider antiarrhythmic infusion. Consider expert consultation. If the QRS complex is narrow, IV access 12-lead ECG, you can do vagal maneuvers to revert the rhythm back to sinus rhythm. Adenosine, if there is irregular tachycardia, beta blockers or calcium channel blockers, which are rate controllers, can be used if patient's BP is above 90 millimeters of mercury. Consider expert consultation early in the course. So doses and details, synchronized cardioversion. The initial recommended dose for a narrow regular complex tachycardia is 50 to 100 joules. Narrow irregular tachycardia 120 to 200 joules with a biphasic machine, or 200 joules with a monophasic machine. Wide regular tachycardia 100 joules to start with. Wide irregular tachycardia defibrillation dose, not a synchronized cardioversion. Adenosine IV dose, first dose 6 milligrams rapid IV push, followed by a 20 ml of NS push. Second dose of 12 milligrams if required. Antiarrhythmic infusions for stable, wide QRS tachycardia. Procainamide IV dose of 20 to 50 milligrams per minute until arrhythmia is suppressed. Hypotension ensues. QRS duration increases to greater than 50%. A maximum dose of 70 milligrams per kg given. Maintenance infusion of 1 to 4 milligrams per minute. Avoid if prolonged QT or congestive heart failure features are present. Amiodarone IV dose. The first dose is 150 milligrams over 10 minutes. Repeat as needed if VT occurs, followed by maintenance infusion of 1 milligrams per minute for the first 6 hours. Sotalol IV dose can be used. 100 milligrams, 1.5 milligrams per kg is the dose of sotalol. Should be given over 5 minutes. Avoid if prolonged QT is present. So I hope you understood. If any doubts, you can inbox me. Thank you.